We are now going to discuss dialysis. The main purpose of dialysis is to help the body remove waste products and excess fluid when renal function is compromised. When the kidneys are damaged, they are no longer able to remove wastes and excess fluid from the bloodstream efficiently. Wastes such as nitrogen and creatinine build up in the bloodstream. Dialysis may also be used to correct electrolyte imbalances when they are critically high. An example is a critically high potassium level. Dialysis is indicated when a patient's clinical status is compromised due to renal failure, overdose, and/or electrolyte imbalance. In renal failure, it is most often instituted once the GFR is less than 15. Those with acute kidney injury may also require dialysis. This is a very simple mnemonic to help you remember when dialysis is necessary. A-E-I-O-U. A being acid-base problems, E is electrolyte problems, I is intoxications, O overload of fluids, and U uremic symptoms. Dialysis work on the principles of the diffusion of solutes and ultrafiltration of fluid across a semi-permeable membrane. Blood flows by one side of a semi-permeable membrane, and a dialysate or a special dialysis fluid flows by the opposite side. Smaller solutes and fluid pass through the membrane, but it blocks the passage of larger substances such as red blood cells and large proteins. This replicates the filtering process that takes place in the kidneys. The two main types of dialysis, hemodialysis and peritoneal dialysis, remove wastes and excess water from the blood in different ways. Hemodialysis removes waste and water by circulating blood outside the body through an external filter called a dialyzer that contains a semi-permeable membrane. In a peritoneal dialysis, waste and water are removed from the blood inside the body using the peritoneum as a natural semi-permeable membrane. Waste and excess water move from the blood across the peritoneal membrane into a special dialysis solution called dialysate in the abdominal cavity. Peritoneal dialysis. In peritoneal dialysis, a sterile solution containing glucose called dialysate is running through a tube into the peritoneal cavity, the abdominal body cavity around the intestine, where the peritoneal membrane acts as a partially permeable membrane. This exchange is repeated 4 to 5 times per day. Automatic systems can run more frequent exchange cycles overnight. Peritoneal dialysis is less efficient than hemodialysis, but because it is carried out for a longer period of time, the net effect in terms of removal of waste products and of salt and water are similar. Peritoneal dialysis is done at home by the patient, often without help. This frees patients from the routine of having to go to a dialysis clinic on a fixed schedule multiple times per week. Peritoneal dialysis can be performed with little to no specialized equipment other than bags of fresh dialysate. Contraindications for PD include peritonitis, recent abdominal surgery, abdominal adhesions or scar tissue, or other GI problems. Siliconized rubber catheter is surgically inserted in the patient's peritoneal cavity 3 to 5 cm below the umbilicus. The catheter is then tunneled under the skin through fat and muscle tissue to the peritoneum. 1 to 2 weeks, allowing insertion, fibroblasts and blood vessels grow around the cuff of the catheter and fixes the catheter in place. This provides an extra barrier against dialysis leakage and bacterial invasion. If the patient is scheduled for transplant, the catheter can be removed or left in place if the need for dialysis is suspected post-transplantation. Different needed substances such as medication and electrolytes can be added to dialysate solution as needed. Each full process of dialysis is referred to as an exchange. One exchange consists of one infusion or fill. This usually takes from 10 to 20 minutes. Dwell time, which is when the dialysate sits in the peritoneal cavity, allowing the dialysis to occur, and the drain time or the outflow is when the fluid drains from the body by gravity into a drainage bag. Before treatment, a patient's vital signs and weight should be obtained. The patient should be instructed to use the restroom if possible, and electrolyte and glucose levels should be assessed. During treatment, it is important to continue monitoring the patient for any signs of complication. Monitor dwell time and prevent going over prescribed time, as this may cause hyperglycemia. If outflow is less than inflow, assess for possible reasons. Remember, the difference is equal to the amount absorbed or retained by the patient and should be counted as intake. Bright red blood or cloudiness in the outflow should be reported to the healthcare provider. Complications of PD include infection of the abdominal lining, known as peritonitis, is a common serious complication. An infection can also develop at the site where the catheter is inserted to carry dialysate into and out of the abdomen. The risk of infection is greater if the person doing the dialysis isn't adequately trained. Strict sterile technique is necessary to decrease the risk of infection. Also, changing dressings when they become wet and diligently scrubbing connection sites will help decrease risks. Weight gain can occur because the dialysate contains dextrose. Absorbing some of the dialysate may cause hundreds of extra calories daily, leading to weight gain. The extra calories can also cause high blood sugar, especially in those that already have diabetes. Holding fluid in the abdomen for long periods may strain muscles, causing a hernia to develop. They may not be as effective as hemodialysis and can become ineffective after several years. The patient may need to eventually switch to hemodialysis. Abdominal pain may occur due to peritoneal irritation during the first few exchanges. Pain usually disappears after 1 to 2 weeks of treatment. Using a decreased amount of dialysate and/or warming before administration may help alleviate pain. There may be an abnormal appearance to the outflow. If it is bloody, it usually indicates a vascular complication. Brown signifies a possible bowel perforation. Urine colored may indicate a bladder perforation, and cloudy outflow is usually seen with peritonitis. The doctor should be notified of any of these abnormalities. The main cause of outflow and/or outflow problems is constipation and/or a full colon. Encourage patients to consume a high-fiber diet and use stool softeners as needed. The catheter may migrate from the correct placement and will require an X-ray to check placement if this is suspected. It is recommended to have the patient change positions and ambulate if outflow is less than inflow. When beginning PD with a new catheter, leakage can occur around the insertion site. After about 2 weeks, fibrin tissue seals around the catheter site and should allow for a full exchange without leakage. CAPD, or continuous ambulatory peritoneal dialysis, is the most portable type of dialysis. It uses manual bags containing peritoneal dialysis fluid and is done every day. Bags are changed 4 times per day, and it can usually be learned in about a week. CAPD closely resembles renal function because it's continuous. It doesn't require a machine and promotes patient's independence. Automated peritoneal dialysis is a type of peritoneal dialysis. It is performed during the night with a cycler machine performing the exchanges while the patient sleeps. Advantages of PD include greater lifestyle flexibility and independence. This can be especially important if a person's work, travel, or home is far from a hemodialysis center. The diet is less restricted. Peritoneal dialysis is done more continuously than hemodialysis, so there is less accumulation of electrolytes and fluid. This allows a more flexible diet than if on hemodialysis. Any residual kidney function is usually maintained longer than with hemodialysis. Disadvantages include the risk of peritonitis, protein loss with dialysate, increased lipids and glucose levels, and is traditionally less effective at removing waste products and fluid. Hemodialysis. Hemodialysis is a medical procedure to remove fluid and waste products from the blood and to correct electrolyte imbalances. This is accomplished using a machine and a dialyzer, also referred to as an artificial kidney. Dialysis is performed using a filter which has a semi-permeable membrane that separates the patient's blood and a fluid known as dialysate. Because this membrane is semi-permeable, it allows water and waste to pass through, but does not allow blood cells to pass through. Hemodialysis is used to treat both acute, temporary, and chronic, permanent kidney failure. The patient's blood is filtered by the process of diffusion utilizing a substance known as dialysate. The concentration of the dialysate will depending on what electrolytes, waste products, toxins, medications, and or how much fluid needs to be removed from the blood. Treatment for hemodialysis usually takes place in a hemodialysis unit. Patients generally go to the dialysis unit 3 times a week for treatment. For example, the schedule is either Monday, Wednesday, and Friday, or Tuesday, Thursday, and Saturday. Before treatment, patients weigh themselves so that excess fluid accumulated since the last dialysis session can be measured. Patients then go to assigned chairs that are like lounge chairs. The area of the graft or fistula, which is the connection between the artery and vein, is cleaned thoroughly. 2 needles are then inserted into the graft or fistula. One takes the blood to the machine where it is cleaned. The other needle allows blood that is returning to the patient to go back into the patient's body. Treatment lasts from 2.5 to 4.5 hours. During this time, the dialysis staff checks the patient's blood pressure frequently and adjusts the dialysis machine to ensure that proper amount of fluid is being removed from the patient's body. Patients can read, watch television, sleep, or do other work during treatment. On occasions, patients who are very motivated may be able to perform dialysis themselves at home in a process called home dialysis. Listed here again are some of what hemodialysis can remove from the blood depending on the prescribed dialysate. Dialysate, also called dialysis fluid, dialysis solution, or dialysate bath, is a solution of pure water, electrolytes, and salts such as bicarbonate and sodium. The purpose of dialysate is to pull toxins from the blood into that dialysate. Temp may be elevated because of slight warming of the blood from dialysis machine. Monitor for bleeding. Heparin is added to the bath to prevent clots in tubing and machine. Patient can eat before or during. Because a fistula or graft matures in about 6 weeks, sometimes temporary catheter must be placed, such as a special type of central line. Nurses should assess the extremity for circulation, temperature, and pulses. Meticulous perineal care is necessary with a femoral catheter, and the patient should not sit up more than 45 degrees or lean forward. If kidney disease progresses quickly or the patient has not had a vascular access placed before needing dialysis, a venous catheter may need to be placed as a temporary access. A nephrologist or an interventional radiologist, a doctor who uses medical imaging equipment to perform surgery, places the venous catheter. Some of these catheters have 2 lumens, 1 arterial, and 1 venous. However, some may have a 3rd lumen that can be used as a central line access. Never flush or access a dialysis catheter without a physician's order and specialized training. High-dose heparin is used in the catheter to prevent clotting. This heparin is withdrawn and discarded, not flushed through the catheter. The best type of long-term access is an AV fistula. A surgeon connects an artery to a vein, usually in the arm, to create an AV fistula. An artery is a blood vessel that carries blood away from the heart. When the surgeon connects an artery to a vein, the vein grows wider and thicker, making it easier to place the needles for dialysis. The AV fistula also has a large diameter that allows the blood to flow out and back into the body quickly. The goal is to allow high blood flow so that the largest amount of blood can pass through the dialyzer. There is a wait period of 4 to 6 weeks after surgery to allow the fistula to mature. The AV fistula is considered the best option because it provides highest blood flow for dialysis, is less likely to become infected or clot, and it lasts longer. If problems with the veins prevent the placement of an AV fistula, an AV graft may be placed instead. To create an AV graft, the surgeon uses a man-made tube to connect an artery to a vein. An AV graft can be used soon after surgery for dialysis. However, there is a higher risk of infection and blood clots. Repeated blood clots can block the flow of blood through the graft and make it hard or impossible to have dialysis. It is extremely important to assess patency of the patient's AV fistula or AV graft by palpating for a thrill and auscultating with stethoscope for a bruit. This is the patient's lifeline, literally, and the physician must be notified immediately if there is a problem locating either one. Here are examples of an AV fistula on top and an AV graft on the bottom. These pictures show how the cannula is placed to allow proper flow to and from the dialysis machine. Hypotension is a common occurrence during hemodialysis in which the dose and speed of the procedure can cause the too rapid removal of fluids from the blood. By doing so, the internal pressure in the blood vessels will invariably drop, sometimes quickly. Large air embolisms can cause strokes or heart attacks and could be fatal. Diagnosis of air embolism can be missed when dyspnea, continuous coughing, chest pain, and a sense of impending doom make up the chief clinical symptoms. However, clinical signs may also include cyanosis, hypoxia, hypercapnia, hypotension, tachypnea, wheezing, bronchospasm, tachycardia, or bradycardia. Dialysis disequilibrium syndrome, DDS, is an uncommon neurological condition that typically affects people who just started dialysis. It is believed to be the body's response to a procedure it considers abnormal, resulting in the reason of the inflammatory cytokines and other inflammatory chemicals that cause cerebral edema. Continuous renal replacement therapy, CRRT, are dialysis treatments that are provided as a continuous 24 hours per day therapy as opposed to intermittent therapy. Both intermittent hemodialysis and continuous hemodialysis circuits utilize the same principles. The major difference between intermittent and continuous therapies is the speed at which water and wastes are removed. Intermittent hemodialysis removes large amount of water and waste in a short period of time, usually over 2 to 4 hours. Whereas continuous renal replacement therapies remove water and waste at a slow and steady rate. While intermittent dialysis allows chronic renal failure patients to limit the amount of the time that they are connected to a machine, the rapid removal of water and waste during intermittent treatments may be poorly tolerated by hemodynamically unstable patients. Nursing management in CRRT includes daily patient weights to assess fluid removal. Because anticoagulation during CRRT can lead to bleeding, nurses must monitor for signs and symptoms of bleeding in the oral mucosa, gastric aspirate, stool, and injection sites. Check coagulation labs regularly. Take steps to prevent hypothermia. During CRRT, about 150 to 250 ml of blood volume remains outside the body in the CRRT circuit. Therefore, blood may become cool and cause the patient's temperature to drop. Monitor temperature regularly. To prevent hypothermia, manufacturers provide warmers for CRRT solutions or blood warmers to warm the blood as it returns to the patient. Using a warming blanket also helps prevent hypothermia.